Hi, this is Dr. Nick Biasotto, the host of the Medical Society of Delaware's podcast, Delaware Health Care Reality. But before we begin, I'd like to do a little bit of housekeeping. I'd like to give very much thanks to our supporters and sponsors, and they include Peak Technologies, the DHIN, which is the Delaware Health Information Network, Platinum Dining Group, Source Pass, and WSFS. The opinions in our podcast do not reflect the Medical Society of Delaware's endorsement of any product. It is strictly for informational and educational purposes only. And lastly, any questions, concerns, or suggestions for future podcasts can be directed to our website, healthcare.reality@medsocdel.org. That's healthcare.reality@medsocdel.org. And we will be happy to answer any of your questions, concerns, or any of your suggestions.
Welcome to Delaware Health Care Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Health Care Reality.
Hi, this is Dr. Nick Biasotto. I'm the host of your podcast, the Medical Society of Delaware. It's called Delaware Health Care Reality. Before I introduce my guest, I would like to give a shout out to all those in the MSD, which without their help, this podcast would never happen. First is Katie Hamilton, coordinator and scheduling, and she deals with the physicians who have already participated in the podcast and get their approval for the release of the podcast to the public. Lynn Robinson coordinates, and she follows our statistics as we go along, which I will give you a brief summary of after I finish the introduction. And Dwayne Downs, he's our techie guy. He's the one that helps us out with the technical problems that we may have with podcasts that may be on Zoom, etc. And he sets all that up. He's definitely needed. Lorianne Rhodes is the voice of the podcast. Tom Minton is our producer, and of course, Mark Thompson, the Medical Society of Delaware Executive Director. I'd like to also say our email is healthcare.reality@medsocdel.org for any of those who have questions, concerns, comments, or would like to give us suggestions for future podcasts. Please email us at healthcare.reality@medsocdel.org. That's healthcare.reality@medsocdel.org. I would also like to go into some statistics of our followers. It's pretty interesting. We are being picked up in 28 countries. Amazing. We have 2,100 daily listeners and 2,500 downloads. It's pretty impressive for working for about a year and a half now, putting season 1 37 episodes, and here we are in season 2, and this will be our 5th episode. So now I'm going to introduce our guest, our newly elected president of the Medical Society, Dr. Brian Galinat. Dr. Galinat was born in Connecticut, received his undergraduate degree in chemistry from Randolph-Macon College and his MD from the Medical College of Virginia. After completing his orthopedic residency at Thomas Jefferson University, he did the Shoulder and Sports Fellowship at the Hospital of Special Surgery. He also completed the Wharton Executive MBA program in 2014. He is a member of the Delaware Orthopedic Specialists and has been in private practice in Delaware since 1989, where he and his spouse Lois have raised their 3 children and now helping raise 2 grandchildren. He claims to now be in a pre-retirement period with his clinical practice focused on surgical and non-surgical management of the shoulder. Of the volunteer activities in his CV, he is most proud of his current role at MSD as president. His time is on the board of directors of the American Academy of Orthopaedic Surgeons and has current position as the member of the board of directors of the 20th Century Orthopaedic Association. He is also the second surgeon from Delaware to be elected to the 20th Century Orthopaedic Association, the first being G. Dean McEwen. When not working, amongst Dr. Galinat's joys are his family, wood turning, golf, harvesting, and traveling. He and his wife Lois have visited all of the U.S. national parks. That's impressive. And he is always making plans for the next big trip. Well, I want to introduce you, Dr. Galinat. Brian, it's good to have you. My first question. When you were introduced as our new president, you did a bit of a speech to us, and you mentioned the things physician first as part of your platform. Explain what you mean by that.
Well, thank you, Dr. Biasotto, and thank you for having me here today. I feel first I should put in a little bit of a disclaimer in that as we have our conversation, I'm responsible for what I say. I am not representing the Medical Society of Delaware unless I say I am, and I'm not representing my group, the Delaware Orthopaedic Specialists.
Very good.
Now, having said that, on behalf of the Medical Society of Delaware, let me thank you, Dr. Biasotto, for making this happen, okay? You mentioned your team. We appreciate that, but let's be clear. It doesn't happen without Dr. Nick, okay?
Oh, thank you.
My pleasure. As far as advancing in our volunteer organization to this level, I'm very proud of it, and what I said in my brief comments at the new officers' reception, where we honored all the new officers, was that when I'm at my home, the cornerstone is my wife Lois, key to our family. When I'm in the office, my cornerstone is patients first, and during this upcoming year, although I don't have a specific goal in mind, my guidepost shall be physicians first, and meaning a lot of what we do at the Medical Society requires thoughtful reflection and discussion, and I'm a very big fan of the wisdom of the room. We have a lot of smart rooms throughout our different committees at the Medical Society of Delaware. And when push comes to shove, the question is it good for physicians?
Okay. If it's good for physicians, it spills over as it's good for patients, is my opinion.
100%.
I think if we are treated properly and we are given fair shake in many of the fields we are in, the patients will definitely benefit from that. So we have a few very important legislative initiatives going on down in Dover at this point. One is Senate Bill 1, a primary care initiative. Can you comment on what you feel about that? And I'll add my 2 cents, too, as we go.
Well, we always appreciate your 2 cents, so don't hesitate. We had 3 primary goals this year. One was prior authorization, and another big one that's been going on for a long time has been primary care reform. We're all aware of access issues, primary care, mental health, and many other specialties for that matter, and trying to provide access while still providing quality care is a challenge for not only Delaware but our nation. SB 1 in particular appears to lay groundwork for building on past legislative activities that have the goal of improving the primary care. The SB 1 is hoped to still provide an improvement in the structure so primary care can stay thriving in our state and we can get increased access that patients so badly need.
Agreed. In my practice, I train and teach interns, residents, and students, and I frequently ask them what do they want to do when they're completing their studies. And most of them say, not what you do, meaning I'm primary care, because I say, why? It's rewarding. They say, oh, it's very rewarding. You become close to families. You almost become like a family member. But they say, I come out of medical school with a $250,000, $300,000 debt. And at the reimbursement that the primary care doctors get today, they would be 60 before they paid off their loan. So they say they would rather go into a higher paying specialty and in turn reap the benefits from that and be able to pay their debt down faster. That leaves America and Delaware lacking primary care, in my opinion. And primary care is the foundation for a good medical practice. We set the record, we set the standard, we give the information, we take care of the patient primarily. and then refer them out to guys like you when I can't fix that shoulder, but you can. So without the primary care physician, how does a patient know who to go to for something like a bad shoulder or chest pain or anything like that? And what do? They run to these urgent care centers. It's jacking up the cost. They run to the emergency room. By the time they end up out of the emergency room, they got thousands of dollars of a bill. So a primary care doctor can stop that right at his door, treat the problem, and set them free, or send them to somebody that can take care of the problem. So I think primary care is being overlooked and treated poorly in this state and in the United States. I understand that the biggest objection to SB1 is coming from the hospital system. Is that correct?
Well, I was unfortunate that I couldn't be at the hearing yesterday in Legislative Hall. I completely agree with what you say about the importance of primary care. I would also say I think it's one of the best jobs in medicine. Everybody has different skills and different desires once they get to medical school, but you hit the nail on the head. I mean, being a great primary care doctor is a very rewarding specialty in healthcare, and it's something that you can do for a very long time. And there's a significant investment in people getting educated to get a MD or a DO degree, and one of the reasons I'm spending time trying to help as president of the Medical Society of Delaware, I've also had a very blessed career, and to whom much is given, much is expected. And I expect of myself to continue to try to use my skills and knowledge to make things better for the future. Mm-hmm. SB1 is a good step in the right direction. I think there may still be opportunities for it to be improved. And you mentioned the hospitals. So the disparity in payment for medical services throughout the country, I don't think is any one person's problem. When I see a patient who thanks me for how good their shoulder feels after they've recovered from their surgery, I share that thanks with the operating room staff, with the company who made the implants that I put into their shoulder joint so that their pain's gone. I share it with the primary care doctor. I share it with the hospital because that's where I do a lot of my surgeries. And I share it with even the insurance companies.
Really?
Yeah, absolutely. I mean, we've both needed health care. Mm-hmm. I've done okay as an orthopedic surgeon. I couldn't pay for the health care that I've needed to keep me here and keep me on this microphone today.
Got it.
Some things are really expensive to take care of and hopefully cure. So I don't think there's anybody involved that has been actively malicious from the start. And then I think everybody at the table has a viewpoint that in part protects what they have, and also the concept of having more money in their corner, in their bucket. They feel, with certain exceptions likely, they feel they're best able to use that money for the good of the people. Now, insurance payers, pharma, they're both for-profit entities, and so they do have a fiduciary responsibility to their shareholders. But without capitalism and pharma's successes, at least, we wouldn't have a lot of the techniques we have to keep people healthy.
Interesting.
So, and the cost of healthcare in our country is known to be high relative to other developed nations, and our lifespan is not top. But if we look at the people who are alive at 65 and check longevity from that point forward, we are at the tops.
Yeah.
So a lot of the research, the medications that are developed in this country and used across the world, I guess what I'm saying is it's a pretty complex issue.
Sure is.
And I'm sure from the hospital's viewpoint, they have a valid argument. It gets back to communication. I mean, I think everybody truly is after similar goals.
Well, let's back up a little bit. When you look at how payments, I'm going into payments because that's what keeps the lights on in my office, okay? That's what helps me pay my staff and give them their benefits. When you look at what I am reimbursed,
It stinks.
it stinks. Medicare establishes what payment structure you fall under, and other insurers usually go by what Medicare says. But when I hear that I get maybe less than 100% of what Medicare offers for that particular procedure,
It's disturbing.
but somebody in the hospital setting gets 250 times more of that.
No, 2.5 times. But it's not only that, it's the facility fee associated with it. Now, that physician who's employed by the hospital is not linked to the CPT RVU E&M system.
Right.
Okay, one of the other things I did, I was on the Coding, Coverage, and Reimbursement Committee for the American Academy of Orthopaedic Surgeons on and off for 14 years.
Mm-hmm.
I went to the RUC, the Resource Update Committee, the RBRVS that the AMA kind of controls and has different people. It's a little bit of a sausage factory. I dipped my toe in that pool and I said there's people better qualified to deal with this. But I gained knowledge, and it is true and no matter what physician you are right now, if all of your revenue is dependent on E&M codes, you're in trouble, okay? And part of that is because there has not been a medical economic index elevation of the conversion factor, which is the number Medicare uses to multiply times the relative value units, RVU, for each additional CPT, current procedural technology number. It's 5-digit code, 99213, follow-up, office visit. So relative to inflation, standard inflation, that number's gone down for all of us who do E&M over the last 20 years, like at least 30%. I mean, the charts, we got them in our head, and I don't know what the exact numbers are, but E&M payment for all specialties. My daughter's an ENT surgeon, in the area. She came back to town. Anybody billing Medicare or a third-party payer, their revenue associated with E&M coding has consistently gone down. Other specialties have had an opportunity to gain revenue from other things. And, it's been 20, 25 years. I remember this cartoon in the New Yorker where the primary care doctor is behind the desk and he's charging for the Band-Aid. I don't know if that was HMO days or before that or whatever.
I don't charge for Band-Aids.
No, nor do I. But it was an example of a long time ago how doctors have diversified their line of business in order to keep the lights on. In orthopedics, we've been able to do that very well, but there are large orthopedic practices that net out nothing from E&M. That's kind of their loss leader.
I understand. Well, I try to do as many procedures in my office that I can do and not have to refer everybody out. That I guess gives me a little more of an income. I've trained to do it. Why not do it? Joint injections, things like that. Biopsies, removal of benign or potentially malignant
Well,
lesions.
at the same time, you were trained to all do that,
Correct.
right? And you've been doing it for, you look
46
young,
years.
I'll say 20 years.
46 years.
But I don't know that the new residents are receiving the training that you did. I don't know that they're given the opportunity to have the experiences that you did.
Mm-hmm.
It's the same thing in orthopedics, okay?
Mm-hmm.
I was a sport/shoulder guy. I came to town, I was doing ACLs, was doing everything, was covering level 1 trauma. And back in the 90s, it was nowhere near as bad as it is now at Christiana. We're the only level 1 trauma center between Baltimore and Philadelphia. It's intense. And again, without the support of the hospital system, the ERs would even have more troubles. We'd see lines up in the urgent care instead of stretchers in the hallway at Christiana. And I don't, we're on the outside, fine. I'd like to see money redistributed in a manner that takes care of the needs of the population, and you're 100% right. More investment in primary care up front would absolutely decrease the downstream cost. The problem in this state is we have a problem. I mean, again, the legislators I've met are great. They're trying to do the right thing. Our new governor is great. Our old governor was a good guy. I mean, nobody's going to work to mess it up. But a potential contributing problem is this one-year budget, right? I mean, they've got to true it up every year, which is good because nobody wants to get taxed higher in order for some future investment. So, it's a little like right now we're trying to rob Peter to pay Paul. Now you have a vowel at the end of your last name. Do you know where the saying "rob Peter from pay Paul" came from?
Yeah, where?
No, I'm asking.
No.
Okay, so
rob Peter to pay Paul.
The best estimation is in the late 16th century, Westminster Abbey, which was in honor of St. Peter, was making good money, but then they became in the same diocese as St. Paul's in London. And St. Paul's in London was having financial problems, so the profits from Westminster Abbey was used to support Paul. Right, so pay
That's an interesting.
And then, the other kind of parallel to our zero-sum game is Robin Hood, okay? So took from the poor, took from the rich, gave to the poor. So, I mean, we're not in Reaganomics or Bidenomics. We're in Robin Hood economics.
Okay.
And unless we can find a way to invest in the future, we will not create wealth, in our state, in our country.
Okay.
So it's hard to do that zero sum because the macroeconomics of it are frightening, right? The aging population has increased. We have a graying of our population. We also have tax refugees coming to Delaware, which is good, but they're coming from New Jersey, New York, Pennsylvania, where the retirees' tax rate is higher, and we have some relief. We're not Florida. We're not, a Caribbean country, but it's pretty good, and we have access to a lot of great things. So that's been a stress on the health system for sure, and how we solve it is not fixing one thing. It is critical, our lack of primary care access for our citizens, and I hope we can continue to focus on making that better.
Interesting, very interesting. Do you think we'll do it in the near future? Do you think we'll ever, how do you feel about, change this, same subject but different direction, how do you feel about one-party payer systems in this country? Do you have an idea? Do you have a feeling? Do you have an opinion? Like have Medicare for all? Some people are touting that. Is it another way to do it? So that we don't have to deal with all the intricacies that we see between each different insurance company. When I deal with insurance companies, it's always this insurance company has this way to do it, this has another way, this is they're reimbursing this way, etc. How do you feel about a one-party payer system? And in your mind, is it feasible?
Well, with regard to the disparities between having our patients qualify for certain treatments based on their insurance payer, this wraps in, second opinion versus prior authorization. I certainly think it would be better for the patients and the providers if there was one set of rules.
Right.
Now, any solution is going to have untoward side effects. The solution of we'll just take indications for, I don't know, what's a drug you prescribe that you have to get pre-auth?
Oh,
just give me one.
GLP-1s.
Okay, GLP-1s, right. So
that's the weight loss medication we're all hearing about, but go ahead.
And it's also going over the counter, I think, pretty soon in some form.
I don't know if it's a form to stimulate GLP in your own system, or is it truly a GLP-1 agonist?
Obviously, I'm not this orthopedic surgeon is not.
But here we have a drug. Here we have drugs that are put out by companies that produce significant weight loss. Now, we know that obesity is a big health risk in this country.
Yes.
And yet I have to go to an insurance company, prove the person. Now some insurance companies paid initially for...
Well, this is the problem.
Just paid for the weight loss drug. Okay, they're obese, they have a problem, and no comorbidities had to be listed before they would pay it.
There's one problem with that, the word some, okay? So different payers have different rules, different guidelines for every, well, not for every drug, but for most. Now, okay, say you and I, we're going to have the Biasotto Galinat decision on all things related to all Americans.
Let's do it.
Okay, now, what have we done if we expand that to everything? Well, your state medical society is no longer necessary. Your state Department of Insurance no longer has to deal with health care. I mean, a lot of medical delivery issues are by state borders, right? My license is for Delaware. I can't go over to Pennsylvania and perform a surgery.
That's correct.
Okay. Now, you want to take it to the extreme. Okay, now we got one ruling body. We're going to let Wyoming decide. They seem to be really good on statistics. I'm making this up in case, you know. Mm-hmm. But now all states are going to follow Wyoming's rule for GLP-1. And Wyoming makes all the insurance companies follow that rule. That can evolve theoretically. This is unplanned, as it's obvious to those in the room, to a single payment method, a single guidance method. Executive Director Mr. Thompson and I and Janice Tilton Burton were at the National Advocacy Conference of the American Medical Association a couple of weeks ago. And we had different congressional representatives come up and talk. And somebody asked us, they were so good. I left that meeting so optimistic that there's hope. They finally figured out that we've been getting the short end for some time, and they're hearing it from their constituents. But somebody asked us, one excellent speaker, well-versed in healthcare, so what's right about Medicare Advantage? Right? We have a ton of trouble with Medicare Advantage.
Exactly.
People are being sold plans that they really don't understand. And now I'm on Medicare, and my lovely wife Lois has helped her parents through the complexity year after year as the drugs come on formulary, off of formulary, blah, blah. I'll go to this pharmacy, but that's my favorite pharmacy. Anyway, his answer, why? Choice. Okay? So it does give people some choice. I don't think they're great choices compared to other options, but it rolls back into the financial decision associated with being healthy.
But some are making those choices on false premises. Don't you think? Because Medicare Advantage was touted as a really fantastic plan. I'm Medicare
okay.
too.
Let's throw that right back at you.
Okay.
A single-payer plan is touted as a fantastic plan for some people, and I agree the complexity of the current system has opportunities for improvement. Mm-hmm. I still think there's going to be good or bad jurisdiction at a local level. I still think there's going to be a number of different payers involved in the system. It'd be the end of too many jobs if it all went away in a poof.
What do you think about this? You want to keep the capitalistic initiatives still there because we are a capitalistic society. Why not take the four quarters of our country, East, Central, Mountain, and Pacific, and assign them a big insurance company? Say healthcare on the East Coast, which is probably the most populous coast part of the United States. Say to them, here's some money, let's say it's Highmark. Here's your money, Highmark, to take care of the people on the East Coast. The government is supplying the money to Highmark, and Highmark utilizes it as seen fit, with the input from physicians on how that should be distributed. You keep some money at the end if you keep everything cool and calm. Right now we're under many restrictions to lower cost of medicine from my office, and I'm sure to yours. So why not allow that to happen, and whatever you do, whatever you get, whatever you save, you're still getting money out of from your insurance companies.
simplification like that. It really is. And there is an ideal world, and then there's kind of the real world. I think we need to keep making incremental steps from the position of the Medical Society of Delaware to do what we can. I think as individual citizens, we should, the best we can, try to stay aware of issues that are in front of us. And we have a democratic society where we have the opportunity to vote, and we have an opportunity to tell the people that we're elected what our thoughts are on things. There's, one of the things that is a plus, I believe, for the state of Delaware is the Rural Health Transformation Program. This was money that was set aside for the 50 states on an equal level, and we're going to be able to have a bigger impact because we're a smaller state as long as we participate properly in the program. And there's great work going on in the governor's office and by Dr. Hochstein, who's now head of the Delaware Health Care Commission, and in addition to being a really big, really good ENT surgeon.
Why not break the United States down into 4 parts, from the East Coast, the Central, the Mountain, and the Pacific, and give each big insurer, the big top-of-the-line insurers, the ability to take one section of the country? For example, Highmark takes the East Coast. Now, there are more people on the East Coast than the mountain region, so they get a swath of money that if they utilize it properly, and the doctors on the East Coast utilize it properly, there'll be a sum left over that the insurers can keep as their profit. Is that even a possibility? Is it workable? Can it be done, in your opinion, in a way that we could keep a bit of the capitalism, make the insurance companies happy, and also make the doctors and the patients happy? But before you answer that question, Brian, I would like to take a quick break.
Information about the Medical Society of Delaware can be found on our website, medicalsocietyofdelaware.org. Questions about our podcast can be emailed to healthcare.reality@medsocdel.org. That's medsocdel.org. Once again, here's Dr. Nick Biasotto.
Yeah, this is Dr. Biasotto. We're back from our break now, and Dr. Galinat will address that particular question that I posed before the break. Dr. Galinat, what do you think about that process? Is that a possibility? Does it make any sense, or am I just off the wall?
Well, that can all be true. I mean, it can be a possibility, and you can still be off the wall. That's okay. I think I don't know much about the healthcare models in other countries in depth. I mean, what you described there kind of sounds like 4 Canadian provinces to me. Every different country's methodology has its own special troubles. Currently, our country is still a really good place. Our state is a really good place to receive care. We always want things to be better. Capitalism is not perfect for health care, but other models also struggle. The macroeconomics, as I think I've already covered, with the influx of people to the state of Delaware has made it very difficult for our state to maintain appropriate services along many different healthcare-related issues. Now, long-term, another 10 years, the mid-2030s to 2040, we're going to see the cost curve bend because the number of people needing care will start to decline. We still have this upside-down population growth or lack thereof issue, and capitalism does better when there's continued expansion of the base. And, we have many less people contributing to Social Security than receiving it in comparison to when it first started. So, again, multifactorial, complex problem. I think Delaware has an opportunity to do good stuff because of our small state. I think we need to continue to communicate with each other in a cooperative, collaborative manner, because I think we all do have the same goals. Recently, we've gotten a little bit of influx from a federal program called Rural Health Transformation, and I think we're heading in a good direction with that, with the oversight of our governor. And there are some bright spots amidst obvious problems, and I remain committed to trying to help improve things to the best of our ability. I don't think there's one solution that's going to work for all interested parties. Some of the market-dominating forces should redirect some of their resources to more of their resources, if they're not already, to primary care for sure. And I do think there's been some effort there, but there's always opportunity for more.
I hope the federal government views it in the same way that you do, and realizes that primary care can be very good for reducing the cost of medicine within this country. My last question to you is another one, and we mentioned prior authorizations earlier. Prior authorizations has been a focus of mine since I was president in 2008. I said in my particular platform I wanted rid of primary care so that doctors can be doctors and decide what patients need. Now, we all struggle with primary care. Patients are not getting their medications on a timely manner and or not getting them at all, or they're not getting the testing needed to improve their conditions. Why do we still have this prior? I know we're tweaking it to make it easier, but we're never getting rid of it. And according to the AMA, it's very costly to the physician in his office, i.e., he has to have somebody on staff fighting for the prior authorization. The physicians have to take time to do a peer-to-peer if they feel the denial was unjust, etc. And it's also costing the insurance industry quite a bit of money. Why do we still have this in your mind, and is it necessary to you, Brian?
Well, every solution usually has as its basis what is perceived to be a problem. I think in this particular situation, there's a large disparity in recommended medical treatment. People who are more financially oriented are going to try to put barriers in the way of proper care, and sometimes they base the restriction in care to either outdated studies or things that don't apply to the particular patient that you or I are evaluating. Prior authorization has been a time-consuming, uncompensated burden on all physicians. I don't think it's necessary, but I can understand the payer's reason for developing it in a good way and reason in a bad way. Good way, people who are not educated well, providing care a little bit beyond their scope of awareness, may rely on expensive tests that would not otherwise be necessary. For example, part of the response to our primary care access issue has been expansion of authority for mid-level providers to primarily see patients, and they are an essential portion of our current medical care delivery system. But they probably don't know how to examine a shoulder as well as I do. And a lot of times I see patients who may have had an expensive MRI, perhaps more expensive if done at a hospital, and it really wasn't necessary. And then I'm dealing with a radiologist report that shows abnormalities that are not relevant clinically. So, if I'm a payer, that seems like one reasonable check rein to decrease expenses. Now, on the dark side of that is the reality that I'm aware that some payers put this in somewhat intentionally to make it harder for their customers, the patients, to receive the care. And then when the patient is unhappy with the services of that insurance company, they can go to another insurance company, because the insurance companies spend more money on patients who use care in the past. That's going to cost them money in the future. And if they can debride those patients from their panel, their profit goes up. That would be kind of the dark way. But the happy part of this story is that another thing that came out of the AMA National Advocacy Conference is that there is a bill going through Congress which is entitled the Seniors Timely Access to Care Act, and the entire Delaware delegation has signed off as co-sponsors of both the House side and the Senate side of this, and it's going to at least require Medicare Advantage plans to implement prior authorization programs. So there is motion in that direction, which it's bipartisan. It appears that it'll go forward. If we can make that happen incrementally, things will be better. If they also do indeed put a medical economic index rise to the conversion factor year over year, that's also part of the reason of my optimism coming out of D.C. I don't think things are going to get better in one fell swoop. Okay, but I also am sure that if we do not participate in the process, the result will be less good. Likely to be bad without participation. I think our state legislators need to know what doctors are doing good outside of taking care of patients. Medical Society of Delaware has done a lot of charitable activities. Individual physician groups do so. Delaware Orthopaedic Specialists, every year we go to Sunday Breakfast Mission for what's called Heart to Souls. We do feet check. We give away shoes. In 2 days, it's March 21st. It's Rock Your Socks for trisomy 21, the Downs population. We've been supportive of that. I had a meeting with the specialty societies that are supported through the Medical Society, and Paula Coe, who's an ophthalmologist, talked about an amazing program. Now, if we can mobilize all the good news about what the physicians in the state of Delaware do, we're going to have better standing in the legislature. If we call our legislators and say, hey, I'm here, if you have any question, please call me related to health. We have to get, as you have for decades, we have to have more people get more involved.
Agreed.
It's the only way we're going to make positive incremental change. I respect your desire for a whole scale. Make it better. Not going to happen, bud. Not going to happen.
Okay. Very good. I often look at this and I say, I've been fighting for this for a long time, and it's just not getting anywhere. And I think that I'm not an overutilizer. I think I see what the problem is. I'll examine that shoulder and I'll say, I think you need this or that. You need a plain x-ray just to see it's an arthritic change as opposed to something wrong with the rotator cuff or whatever. And I have been told that you don't overutilize. Why can't they give me a gold card so I don't ever get questioned? Now, the overutilizers, they have a record of that. They have a way to follow that one. If they just let them be educated on how to order that test properly. That's all I'm asking. Then that would make life easier for those who do it right and, maybe educate the ones that are doing it wrong. Well, I think this has been a very interesting conversation. You've taught me something just listening to you. I appreciate this. And I hope that we have you back someday to tell me about how you do shoulder surgery.
No, I would rather talk about where I travel and other stuff related to my grandkids. But whatever you want to do, I'd be happy to come back.
Well, my interest is a little bit in woodworking too. I don't turn. I was starting to do turning, and I never got around to finishing up. But I like to make furniture and things like that. I'm also have a hobby with astronomy. I love astronomy. I have a huge telescope. And doctors need to have these kind of things to escape.
Yeah,
and golf, we got to get out on a golf course one of these days.
That could be frightening.
Could be. Then this is Dr. Nick Biasotto with our guest, Dr. Brian Galinat. And we will be probably releasing this in a couple, 3 weeks. But I want, again, to give you some information about how to get to us with questions, comments, or concerns. and possibly giving us ideas for future podcasts you may be interested in by sending to our email, which is healthcare.reality@medsocdel.org. That's healthcare.reality@medsocdel.org. And this is me signing off till next time.
This has been Delaware Health Care Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. The executive producer of Delaware Health Care Reality is Mark Thompson. Delaware Health Care Reality is produced by Tom Mitten. For the Medical Society of Delaware, I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the host or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.